Now I would like to request ED sir to say few words to the audience. Thank you so much, and over to you, ED sir.
Good afternoon, everyone. I hope I am audible. Could someone confirm in the chat box?
Yes, sir.
Audible?
Audible.
Okay. So, okay, thank you. Thanks for confirming, Dr. Hina. Great to see the participation from all over India of of all categories of healthcare workers, and Dr. R.K. Dhamija, who's the expert, and Dr. Sangeeta Sharma, and also all the participants. I know it's a Saturday afternoon, but I think we've kept this deliberately for there's a time when everyone can devote about an hour plus to such important lecture series. So continuing with our lecture series, today's topic is something which is beyond the medical realm. It's, if you see, the impact of epilepsy is is psychological, is social, cultural, and also on the employment, financial. So it's not only the medical management as such. When we talk of epilepsy, we also have to talk about all these issues, including the how culturally in each culture, in each kind of society or social networks, how epilepsy is looked at upon, rather sometimes looked down upon also. So how and how to address those issues too. But before that, we all must be on same page as to the medical management of epilepsy, including the diagnosis, because the cognitive and intellectual decline in many of these patients is also a possibility if not managed well. So today's topic, I think, is very important. It's not only the medical, but entire affects our society. As I mentioned earlier, I would like to repeat again, the socio-economic, cultural, and other factors which are associated with it, and the individual's ability to earn a living is many times severely affected because of many jobs being, as it is, out of bounds for those suffering from epilepsy, and many times the employers not employing anyone with a history or anyone on medication of epilepsy. So how to address the social stigma also, I think we need to discuss this and highlight whenever we talk of epilepsy. So the burden of disease, it's estimated in India that about 10 million persons with a prevalence of almost 1% population, more in rural 1.06 and much lesser in urban, which is 0.6, 1.9 and 0.6. And even if you see the gap in treatment, it is much more in rural areas, almost 80 to 90%, and lesser in the urban areas because of the various factors which we know. And resources as it is are limited in our country. It's with the people as such. So we have to reduce the out-of-pocket expenditure also on these drugs. And so now with the health and wellness centers coming up, in the newer packages of services, the MNS package of mental, neurological, and substance abuse, epilepsy is included. So the healthcare workers are being trained at the sub-center level, health and wellness center level, PHC sub-center level, and also obviously those at CHC level and district hospital level, with defined referral pathways, including the teleconsultations which are available even at the HWC level. So you have to leverage these options available, and also with the free drugs initiative, and also now with the new push under the PM BEAM and Finance Commission with the defined specific funding for drugs. The anti-epileptic drugs are available, and if they are not available right now in full quantity, if there are stockouts, we are working with states to make sure that they utilize these funds effectively and efficiently and make these available at the sub-center level for all the patients of that particular sub-center, health and wellness center. So with that, what is then important? We are saying the drugs should be available, but if there are no standard treatment guidelines, then it could be any kind of drugs which are available, or some drugs are available in a particular month, some other drugs are available in another month. So that needs to be ensured that the drugs which are prescribed, generally there has to be standard treatment guidelines, so that we can sit with the states and say that these are the STGs, these are the anti-epileptics which have to be made available at all times in all the health and wellness centers, and also, of course, in the CHCs and district hospitals. Definitely, they have to be definitely made available. Rather, some higher kind, if we say that some people need referral and management at a higher level, though some other drugs could be there. So in that context, I think today's seminar, we will look forward to talk by the expert, Dr. R.K. Dhamija, and also, of course, please share with us your experiences also from the field, because you all are working on ground. In fact, I would be very happy if in chat box you could also share those working at the health and wellness center level or at a higher level, or those working at the district or state level as nodal officers, or even the medical officers of PHCs or working at a higher level. Share with us in chat box the challenges being faced by you, the training which has been done, what is the quality of training, do you feel some kind of retraining is required so that appropriate skills are available to are there with everyone, all levels of healthcare workers, and also on at ground level, what how we could work with you to make sure that everyone has that capacity to identify, to give the immediate treatment, and then of course refer and follow up once they are put on referral. Follow up, look for some kind of sign symptoms in case of any pre seizure, and at the time the immediate action could be taken, and in case of a repeated seizures, a referral could be done. So this session should be not only one way of everyone listening to the experts, but also as a cross learning for us, where we learn from your experience on this important issue, which is beyond medicine, which involves the entire society, with a lot of attendant beliefs, the practices, and also stigma and economic loss I've already mentioned to the person who has this, and also sometimes affecting the entire family. So with that, I will stop here and hand over back to Dr. Chinmay Swain to continue with the proceedings. Thank you very much. Wish you all the best for this seminar.
Thank you so much, sir, for guiding us and give us the words of wisdom. So now I will request Shangita ma'am to say something and to start the technical session. Over to you.
Thank you, Dr. Kotwal, for organizing, hosting this program in collaboration with the SPRUD, and thank you for the introducing the topic to all of the participants here. Today I had some glitches, technical glitch for joining, so it. Can you, Annapurna, can you start my video? I'm not able to unmute. Oh, sorry. Oh.
Sure. You can share it, ma'am.
Yeah, no, it's not allowing. Allow. Okay.
You start from here. There's something wrong with the WebEx today.
Yeah, I think it asked for registration, and
Yes.
registration
Yeah.
ID it wasn't accepting. Anyway, your team helped me to join it. Very good afternoon to all of you once again for this session. I hope you will take home certain messages from here. Before we continue with the session, we have a small questionnaire for you. I think this is the link has been put in the chat box. Please click on this link and try to fill up this as early as possible. This would be required because some of you who want certificate to be issued for attending this session, besides the attendance, we would need pre and post questionnaire from your side. So I think we can wait for 5 minutes. You have, please look at your chat box. This link is there. Chat box. Mobile number. It says no. There is nothing. It's an open answer here. It says number. because we need a number, because this will be used as a, if in case there is any problem in the name, or while at the time of issuing certificate. Maybe I'll do that. Are you able to do it now?
We have shared it in link. Dear participants, link has shared in the chat box. Please go with that, and you can yeah, go with the answers. There are more than one answer also in the questionnaires. You can go with more than one answer to click it. So it's we give around 5 to 10 minutes so that you can complete your pre-test questionnaires. Thank you.
I hope you are able to do this phone number and designation now.
Yes, ma'am. It is okay, ma'am. We are also trying with that. It's going on.
Okay. I'm once again posting this link in the chat box. Those of you who have joined now can go to, see that. Please hurry up. We haven't got only 16 responses as yet. Those who complete pre and post only will get a certificate for attending the session. You have to click on this link in the chat box. There is a forms.gle. You have to click on this. Then only you will get the questions. As you go down the questionnaire, you will find questions. I hope should we start? Otherwise, we are getting late for the session. We'll not be able to complete it.
Please put 0 in designation and mobile number as it is not taking full. But the email ID is taking with full. Then you can add your email ID and name completely and submit the form.
I have removed this as a required item, so you should not have any problem with the mobile number. You should be able to submit your questionnaire. How many people are there, Annapurna?
$138, ma'am.
But only 60 people, around 60 have filled so far. Anyway, we presume that they don't want an certificate. Okay.
We'll wait for another 2 minutes, ma'am.
Yes.
Maybe in the end of the submission.
Okay. Can you see my screen?
Yes, ma'am. I can.
It's there, no? Okay.
Yes, ma'am.
Okay. Shall we start? I think we should start. Okay. You can see my screen.
Yes, ma'am.
I can, okay, we can quickly discuss the questions.
Okay, ma'am.
Okay, the first question was about which statement about the treatment of adult patients with iron deficiency anemia is most accurate. The correct answers have been given by the ones in green are the correct answers. The blood transfusions usually are not reasonable first option for most patients, and also parenteral iron therapy is not safe in all trimesters. It is contraindicated in the first trimester. Besides being contraindicated in the first trimester, parenteral iron therapy has its own adverse drug reactions, idiosyncratic reactions. So the patient may get a severe anaphylactic reaction, and sometimes deaths have been reported. Now we have several parental drug iron preparations available, with which the incidence of these idiosyncratic reactions are lower, but still it is not free of the entire free of these idiosyncratic reactions. And for good iron absorption, the iron supplements need to be spaced with tea, coffee, calcium, milk products, because otherwise they chelate with each other, and the absorption of both calcium and this iron is inhibited because of this drug interaction. So we should take care whenever we see that the patient is not responding to adequate iron supplement. Please look into it, the way the patient is taking these medicines. Very often the reason is that iron and calcium are being taken together, or iron, calcium or milk products are taken together. So in ANC clinics you do prescribe these both, so you have to really look into this. And also if these iron supplements are taken with vitamin C, absorption is better. Then there is a notion amongst clinicians that parental iron therapy leads to rapid rise in hemoglobin. Of course, in acute setting where there is acute severe anemia, where the patient needs blood transfusion immediately, the parenteral iron therapy leads to rapid rise here. But if you look at the over a period of 12 weeks, the rate of rise of hemoglobin is the same as the oral. So many of us believe that the oral, if we give it parenterally, the hemoglobin will rise rapidly, but it is not true. Acute blood transfusion setting where you are not able to administer blood transfusion, maybe yes, but over a period. So only indication for parenteral iron therapy are when patient is not able to take it orally. So the role of parenteral iron is quite limited here. Then there was a second question about medication reconciliation should be conducted. Yes, I think a very good response has been here. This should be at least done at the time of admission, at the transition point when the patient is being transferred from one place to another within the hospital, from OT to ward or from ICU to ward, or when the patient is being discharged, and also before prescribing new medication, because very often it is seen that there is a duplication of medicine or omission of an important medicine takes place, because the list of medicines being taken by the patient is not up to date, and sometimes they are consulting several clinicians, each of them may be writing the same medication, so that's how it gets duplicated. Or some of the time, the patient may not share their prescription with the doctor treating physician, so some of these get omitted. So it should be done at all transition point, and at least on admission and at the time of discharge or adding new drug. A prescribing cascade occurs when, I will be talking about this to save on time. I will take up this in detail, but around 60% of you have said correctly. It is not that the patient is deteriorating, so the cascade occurs, or in limited life expectancy results. It is because we are adding on drugs to treat the adverse drug reactions of the first drug, and then the adverse drug reaction of the second will lead to addition of a third drug. This is what is called a prescribing cascade. Then clinical presentation of jaundice is appreciated clinically when many of us have this notion, when you see the skin discoloration or sclera discoloration, yellow discoloration, then only it is they are able to see this even with a slight rise in bilirubin. This will be seen only when the serum bilirubin is greater than 3. So that means the jaundice the bilirubin has been rising in between earlier also. Very often we use this term polypharmacy. What do you mean by polypharmacy? Although there is no defined definition, but most commonly used definition is when people are taking more than 5 drugs. Multiple medications may be justified for managing comorbid conditions. Multiple medications may be prescribed for the same disease. The prescription of 2 drugs that may interact to result in adverse, these are all wrong options. Usually general, we take when patient is taking more than 5 drugs, without any other comorbid conditions. When there are comorbid conditions, certainly more number of drugs are prescribed, especially in elderly when they have multiple comorbid conditions. Now there was a question about emollients should be applied all over the body irrespective of the presence or absence of lesions. Hydration is required throughout the body. It may be because of the hand washing, to use of sanitizer, or because of the some dermatological condition like dermatitis, eczema, psoriasis. The function of emollients is to restore the barrier function by restoring the function and appearance of the skin layers. So generally it needs to be applied all over the body. It is the general skin changes that cause the type of emollient, or duration and all that is decided by the medical conditions. Now, which of the following are safe practices to avoid medication errors? There are, when we write prescriptions or when we take notes, transcript treatment from the clinical case notes to the drug registers, there are times when errors happen because the way we write this prescription can lead to problem. For example, how do we use this decimal? While a decimal before a dose strength is required, for example, if it is 0.5 milligram dose, for example, alprazolam is given in that dose, or thyroxine, you may give in a dose of 50 micrograms. So you have to write 0.5 milligram here. So decimal here is required. Suppose if you don't write a 0 in front, this decimal may disappear because the prescription was torn or mutilated or something fell on it. So the patient may get 10 times the higher dose. So 0 before a decimal is required, but zero after the whole number is not required. For example, if you write 5.0, again it can become 50 milligram if somebody is not careful about it. So you have to be really very careful about putting the decimals, and a nurse should not prepare all the medications beforehand and hand over to someone else. It is the rule that whosoever is preparing a medicine must go and administer the medicine, and it is always preferred that the drugs are prepared at the bedside and not at the nursing station, because again this can lead to errors and patient getting wrong injections. And then vitals, regarding vitals need not be checked every time before administering a medicine, but certainly before a medicine is administered, one must assure, cross check it is the same patient. So usually this is usually done by name, checking the name and the registration number, and if you have a barcode, you can do it by that. If the patient ID band is there, it can be done, but vital frequency may be depending on the clinical condition of the patient, it can be recorded. Yes, definitely the fourth option, the before you administer any drug, allergy status must be inquired and must be written on a uniform place on the clinical case sheet of the patient. In no circumstances you should leave this empty. Empty column may mean that there is no allergy history, or it may just have happened that you had forgotten to take the history. So if there is no history of allergy, you should write no known allergy. Then everybody knows, and that this patient is allergic or this is not allergic. So this is the correct option here. Then which of the following statements are correct with respect to acid reflux? Here I have some questions here, because the treatment usually depends on the correct diagnosis. Standard treatment guidelines will apply and would be helpful only when you are sure that the correct diagnosis has been made. So many a times we do not make the correct diagnosis, and then we say that these drugs are there is no response to these drugs. So some of these symptoms, acid reflux can cause sore throat, hoarseness of voice, can cause chest pain, it may mimic angina, chronic cough. Cough is a very common presentation. They may come up with this, or the asthma may not get controlled, symptoms may not get controlled. So it could all be because of the acid reflux. So for STG to work out, the diagnosis needs to be correct. Then regarding this option about eating less, not lying down immediately after eating, these are the non-pharmacological treatment which are equally important as the pharmacological treatment. So many times we lay more focus on the pharmacological treatment and forget about the non-pharmacological. So acid reflux is something, we can initially try patient doing these non-pharmacological interventions to improve their system. And then this last option about omeprazole, usually once we take a decision, the patient continues on with omeprazole. And I have seen many patients continuing on omeprazole indefinitely, because when you attempt to stop this omeprazole, there is rebound acid production, and the patient may have symptoms again. So every attempt for withdrawal is failing, and then that's how omeprazole continues. And we don't care much about it because we think that this is harmless. Omeprazole PPIs indefinitely are not harmless. There are many side effects associated with it. The patient may get bone loss, fracture. The patient is more prone to get infections. So especially omeprazole should not be continued for more than 8 weeks. And except those who have are high risk patients where you need to take it, but generally try and taper this, stop this omeprazole after 8 weeks of therapy. Then there is a question about a child with febrile seizures is likely to develop epilepsy in future. Children with developmental delay and children with family history, they are more prone to get epilepsy in future. Even in family history of seizures, those with the complex seizures, they are more prone. But number of multiple seizures within 24 hours is not an indication, is not condition which is likely to develop epilepsy in future. Because these questions are important, because the moment the child has these febrile seizures, parents are worried and they ask you very many questions, so you need to know how to answer. Anyway, we have Dr. Damija with us today. Maybe he will throw more light on some of these aspects. Now there is a next question about what is the maximum number of puffs per day of inhalation, bronchodilators, for example, formoterol. These are very effective ways of delivery of drug directly to the site of action here. Most often, either we are not giving enough dose of these bronchodilators by inhalation route, or sometimes, when the patient is not responding, it is due to, either the canister was empty or the technique by which this inhalation was taken was not correct. And and many a times we are too early to arrive at a conclusion that this is not working because we haven't given adequate dose. So that is how the maximum number of puffs that you can try and see before you label that the patient is not responding is with formoterol it is 12 puffs, ethylene 8 puffs can be taken at the interval of 5 minutes each. You can repeat them at the interval of 5 minutes from each. Then next is about which of the following is correct regarding management of epilepsy. The correct answer is you start with the monotherapy and add another drug if seizures recur, depending on the frequency of the seizures. Neuroimaging is not required. And do's and don'ts, when the patient is having seizure or when the patient is being transported, being referred to a higher facility are very important. Patient should be transported in a left lateral position and like that. And sometimes some people straight away start with combination of anti-epileptic drugs, which is also not warranted. Then last option, this is very important, these are the two, dilantin or aptoin can be substituted depending on the situation or the availability. These are the two popular brands of phenytoin. These two brands have different strengths. One is 30 milligram per 5 ml, another is 50 milligram per 5 ml. And phenytoin is a very narrow therapeutic margin drug. So a small increase in dose can lead to overdose, or small error in the dose can lead to subtherapeutic level, and the patient may continue to have seizures. So while we have this notion that all brands are equal and any brand can be substituted with other, especially with certain drugs like phenytoin, lithium, gentamicin, thyroxine, we have to be careful. For others, we need to be careful. You can do the substitution, but again, another example is iron supplements. What you get in the market, all of them are not equal. So please look into the strength of the brand which you are prescribing and prescribe a dose accordingly. I hope with this, the questions are answered. I can I, now go to my presentation. Okay, can you see my presentation now?
Yes, ma'am.
Yeah, okay. So I'll quickly go into see with pharmaceutical management, there are two important issues. One is that you select these drugs properly and then use them properly. But we know I'll not go into this. Present day situation is that a lot of out-of-pocket expenditure is being made by the patients, because either those drugs are not available in the hospital, or multiple drugs have been prescribed to patients, and which are not available in the health system. So if you want to improve if you want to improve the access to essential medicines, we need to ensure that these drugs are used rationally, and they are available at affordable prices, and there is a sustainable financing. It should not happen for some time of the year drugs are available, and sometimes of the year drugs are not available. And also, for all these three to be optimally utilized, you need a reliable health and supply system, so that uninterrupted supply of medicines can be made to the patients. So unfortunately, even if one leg of this cable is out, for example, most often it is seen that the rational use of drugs or rational selection is out, so it leads to imbalance and poor access to essential medicines. And if you look at the definition of rational use of drugs, it requires that patients receive medicines appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and at the lowest cost to them and the community. Now each of these statement words is very important. When indicated, then only you use these medicines in doses that meet their own individual requirement. For example, if it is a child, you must be able to dispense those dosage forms which are suitable for a pediatric patient, or for an adequate period of time. If a drug is required for 5 days, 7 days, 1 month, 6 months, depending on the duration, the clinical condition, it should be available for the entire period. And now you would say, why have they included at the lowest cost to them and to the community? Somebody is paying for these. In private sector, yes, lowest cost is directly is related to the patient's out of pocket expenditure. But in public health system, we are not able to appreciate this much. But it is taxpayers money which is funding, financing these all the drugs in the healthcare system. And if you look at the amount of budget spent on drugs after salaries, it is the drugs which consume the largest proportion of the budget. So if we use them properly, we can save a lot of money, and lot many patients can be benefited. And that is why this concept of essential medicines has been given. The essential medicines are those that satisfy the priority healthcare needs of the population. We are not talking about uncommon or rare diseases here. We are talking about making supplies of these medicines regularly to those patients, which form bulk of our outdoor department, which form bulk of our indoor admissions. So therefore they should be available at all times in adequate amounts and in appropriate dosage forms. So that is why every hospital is supposed to have a essential medicines list, so where you try and limit the range of carefully selected essential medicines, so as to achieve better health care, better drug management, and lower cost. And no primary healthcare system or public health program can sustain ऑन कर दो ना, बंद क्यों कर रहे हो? तो क्या हो गया, ऑन तो आएगी तो आ जाएगी. healthcare and fundamental public health strategy. So this will help in quality use of medicines and real health gains. But unfortunately, what is happening current practices, there is a huge variation in clinical practice. Many a times we are mixing up past practice. I've been using this medicine for several years. There has been no problem, or my patients have been responding. There are certain medical myths. We are trying to treat diarrhea, common cold with antibiotics, where we know that this is viral in nature, and there is a clear evidence that this will not help, but still we continue. And also yet another, because of this Clinical Establishment Act and this Consumer Protection Act being enacted, we have resorted to defensive practice. Defensive practice here, just in case, the patient may be having this problem as well, so I have prescribed this. Just in case I may have missed a diagnosis, we prescribe a lot of investigations. So all of these, are adding to the increased healthcare cost and increased demand for care, and equally they raise the patient safety threats also, and rising litigation is because of these variation in the practices. Much of it is because there are a lot of thousands of drugs formulations which are available in the country. Around 40% of the drugs which are available in the country are fixed dose combinations, and most of them, except a few which have been recommended by WHO, most others are dubious. When we combine antipsychotic, antidepressant, anticholinergic drug, sedative agent in one pill, all in the name of raising compliance. Very often you see any patient who has a history of myocardial infarction, they'll get all three. They'll get aspirin, they'll get clopidogrel and atorvastatin, all in one, combined in one. The reason most often given is that it improves compliance. And also because of this, I have reservations about this, because there is a extensive marketing by the pharma industry. So are we mixing up or overrating patient convenience so much that we are giving unnecessary medicines in FDCs? Usually we step up therapy. Patient comes to you, you start with one drug, doesn't respond, then you add another third drug, like that, depending on the patient's response, drugs are added. But sometimes, except for few clinical conditions, unnecessary drugs are combined right at the first step. So we need to look into it, whether we are mixing up combination therapy with convenience. There is a huge growing dependence on private sector, and on the lighter side it says, one of the side effect of this is poverty, because patients are not able to afford these treatments, because 50% more than half of the consumers, they buy one day's supply at a time. They don't complete treatment because they are not able to afford it. And then we say, the drug is bad or the patient is not responding. We need to look into this aspect as well. So there is a global epidemic of irrational use of medicines, and polypharmacy is one, as I said. And it is just like, when everything is right with the life processes, it is called physiological. When something goes wrong with the prescription, it is called pathological. So irrational, when a person can be treated with one or two or maximum three drugs, if we are treating them with more drugs, or we are using expensive new drugs for the treatment, where the patient could be easily treated with the cheaper generic drug available in the market for many decades, this would amount to irrational use of drugs. Many a times we write medicines because patients are complaining, having non-specific complaints, and for their satisfaction we write some vitamins. So but that leaves a wrong notion in the minds of the patient, that there is vitamins are the answer for their weakness. Maybe there are certain other things that need to be looked into. I have few examples here. These are real life examples, prescriptions here. Only thing is I have just put them here in this slide format. But you look at the number of drugs prescribed. Of course, you may say that this is an elderly patient. There are multiple comorbidities. But unfortunately, if you look at today I don't have the time to go into each of these drugs properly, but if you look into it, each drug was added at the patient was having some symptom or the other. It's more like appears like a symptomatic prescription to address some of the symptoms presented. And unfortunately what happens is that this we have this habit of writing continue same treatment. So this how continue, and especially those elderly patients, those who get reimbursement from CGHS or DGHS or from their organization. Sometimes I have seen prescriptions as long as having 25 drugs in there. So one patient in RML I saw was receiving three the diuretic agents from different prescribers. And then again, if you look at this, this is a abdominal pain with vomiting, young patient. Buscopain is for abdominal pain. Ranitidine, perhaps he has not made any diagnosis. What is this cause of this abdominal pain? Buscopan slows down the small intestine. Metoclopramide is a hurrying agent, so opposite effect is there. Ranitidine works in acidic medium, whereas digoxin is an antacid, will make it alkaline. So again, opposite effect. Then tablet metronidazole was given. Again, this patient was already having vomiting. If metronidazole, one of the very troublesome side effect with metronidazole is vomiting. So this is going to exacerbate his symptoms only. So but we do see these kind of stereotyped prescription always. And also, this kind of situation is very common. You prescribe a medicine to a patient. Patient comes back to you, says, this is giving me pain in my stomach, and we prescribe another. I think it's not difficult for you to guess what drug would have been prescribed here. Can you write in the chat box? And this has become a routine that any patient you write any prescription, omeprazole has become a indispensable part of the prescription. Anytime any analgesics are written, people are writing, instead of asking patients to take it full stomach or take it after meals, or identifying which drug is causing more acidity, we are resorting to omeprazole, and then the patient remains on these drugs. So this is what is happening. Prescribing cascade is becoming very common here. You get a patient with a particular diagnosis, you write a prescription for this, and the patient comes back with an adverse drug reaction, and then you identify this as a new symptom and add another drug to treat this adverse drug reaction, and yet another side effect will be there with the second drug, and a third drug would be added. Very common example you may be seeing is for example, patients on of osteoarthritis, they are receiving painkillers, analgesics, they are put on these analgesics. There is a fluid retention with these analgesics. It leads to hypertension. Because of the fluid overload, hypertension is there, so you add another drug for hypertension. Now with hypertension, if you add antihypertensive drugs, for example, if you had added ARB, this losartan or telmisartan or enalapril type of drugs, there would be cough with that. So yet another, the patient will be put on cough syrups. This is very commonly seen. It's not, you may be thinking, who does that, but this is quite very common, especially in our practice in neuropsychiatry where I work. It's a neuropsychiatry institute, and we do see these schizophrenia patients, antipsychotics are started. They have this extrapyramidal side effects. For that, anticholinergics are added, and then you need anti-Parkinsonian medications for this. So that's how the cascade goes. This is ACE inhibitor leading to postural hypotension, and the patient may come and tell you that I am having dizziness after starting with this drug. So for this if you misdiagnose this dizziness as another problem, you add another drug to treat. For example, you add prochlorperazine for this patient. Now this prochlorperazine will have exacerbation of postural hypertension and may lead to falls and hip fractures, especially in elderly. So this is what is prescribing cascade. We must look into it, that these should be avoided. Another reason for polypharmacy is that we repeat prescriptions, and this is the easiest way. CST, never knowing what was there earlier, what is being continued, discontinued. You have to always see what all medicines need to be continued, stopped, or tapered. But with this CST business, all of this gets continued. So I think I already told you about, we need to be concerned about misuse of proton pump inhibitors. It can lead to rebound, hypersecretion, diarrhea, dizziness, fatigue. Then because of the magnesium deficiency, it can lead to calcium and magnesium deficiency. And there are reports of uh, cancers, but not yet proven, but there are some reports. Then another problem with the prescription is overuse of antibiotics, overuse of injections, when we can treat with oral medicines well, but still we prescribe injections. Antibiotics, we know, if we are day in and day out writing antibiotics, even if it is a viral illness, 90% of the time we know that it is viral, but still, just in case the patient may be having secondary infection, or just in case this is the secondary infection right in the beginning, we are writing antibiotics, which is leading to lot of development of resistance. Then incorrect medicines, multifold. When you can treat, if patient is having 2 or 3 problems, symptoms, the endeavor should be to select a drug with which you can answer both the treat both the symptoms. But since more or less these prescriptions are symptomatic prescriptions, we keep on adding. And the use of drugs, underuse is equally a irrational use. When needed, if you don't use a medicine properly. Asthma is undertreated, epilepsy is undertreated. Patient is in need of a medicine, but we are not giving. So that also amounts to irrational use of drugs. Then unnecessary expensive drugs, tonics and multivitamins for malnutrition patient. This is criminal. I find it criminal. The malnourished children being prescribed Dex Orange, the most dubious iron preparation and the most expensive iron preparation, which is being prescribed to a malnourished child. A child is malnourished because he could not afford a square meal, and we are writing something which is very expensive and for which efficacy is also not known. We are, where are we, taking? And I was looking at the top 10 sold medicines in the country. Dex Orange was the number 5 drug in that list. Cough syrup, this Fencidil and Corex were the number 1 and 2, and Dex Orange was the number 5 drugs. So please look into this. Look at if the disease can be treated with vaccine, prevented with vaccine. And use of combination drugs where you can manage with single drug, and use of abbreviations. This is making prescriptions error prone. There are many factors responsible for it, but I feel the most important one is it's a vicious cycle. We say that we are writing because patients are demanding and because they expect this from you, but then if you talk to the patient, they say, I'm taking because my patient doctor is prescribing it to me. I am in no position to judge what all medicines are needed. Especially this happens with the antibiotic. We assume that there is a patient pressure. There are certain patients who are pressurizing, demanding, but we should not be generalizing these. Not all of them. Most of them are looking for this thing. Then even if we want to write this, we want to know this, how is this happening. There are lots of gaps between the evidence and the practice. If you are looking for what to write, what not to write, if you are looking at the internet, you may find differing reports, one agreeing with other, the other not agreeing. There may be a good evidence, there may be a bad evidence. So it may leave us to a very confused state, whether to do it, use it or not. For example, during COVID time, ivermectin was something, people didn't know whether ivermectin should be used for prophylaxis or of COVID or not. There, half the literature said yes, it can be used, half the literature said it cannot be used. So as a prescriber are looking forward to a straight answer whether it should be used for prevention or should not be used. So you're looking for that kind of evidence which is up to date, objective, unbiased, something not coming from the pharmaceutical industry, and which is contextual in your own situation, because we are all working in resource constraints settings, in rural areas where we may not have enough uh, you know uh, infrastructure, personnel, diagnostic support. So these needs, and also we have to make decisions, because we are working with limited resources, and we have lots of problems to be taken care of. Earlier it was only infectious disease, but now the burden of disease has doubled, trebled, tripled now. Besides mother and child health, we need to look at tuberculosis, cancer, diabetes, roadside accident patients coming in. So one suboptimal decision about a drug, if we include a costly drug in our system, and then it can leave other patients from their essential medicines. So we need to make these decisions. You know these are the various kinds of ambulances which are available. Although the Mercedes, this type of is the most well equipped, ACLS is the most desired ambulance, but this may not be the right option. This would need roads to ply. Perhaps then this bicycle would be the most appropriate, because we want to reach to the patient here. So you have to make these decisions keeping in mind the value for money in healthcare. So that is why we are holding these sessions to improve use of drugs. There are certain educational interventions that can be done. For example, today I'm trying to inform you, persuade you, what to write, what not to write, what to be careful. And then there are other interventions, managerial interventions, things like standard treatment guidelines. So we need to be looking at this very carefully, whether our prescribing practices are aligning with the standard treatment guidelines or not. We need to especially see we need to comprehensively do a discharge planning properly, and so that the patient is adhering. Very often we make this decision that this drug is not effective, और वो जन औषधि वाली दवाई है ना, या वो generic वाली दवाई है ना, this is not effective because this is from the जन औषधि or a generic drug. Very often it is that the patient is not taking these drugs properly. The patient has not been convinced. He has his own misbeliefs, myths related to the treatment. He may not be taking the full dose or a full treatment. So medication reconciliation is important. Many patients are taking treatment from multiple providers. They are taking over the counter medicines. They may be taking Ayush medicines. They may be taking some herbal medicines, which they may not tell you. So it is our duty, whenever we get a chance, we must reconcile and make an up-to-date list so that we know what all possible drug interactions can take place, and perform regular re-evaluations, particularly those who are at high risk, those who have heart problem, diabetes, COPD, those who are taking polypharmacy. Whenever a patient is on more than 5 drugs, expect something to go wrong. Some ADR will happen, some medication error will be happen. So proactively follow, prevent this prescribing cascade, especially, start with low dose, tailor the dose to reduce the risk, then reduce the dose of the medicine causing the dose, and see whether the temporal relationship between the appearance of the side effect will help you. If this side effect appeared after a drug was started, most likely it is the adverse drug reaction. So, but if it had been there earlier also and it exacerbated after starting this new drug, think of exacerbation, maybe then reduction of the dose will help. Only continue, add second drugs when you think that the original drug outweighs the benefits, outweighs the risk. Then de-prescribing is very important. We are very good at stepping up therapy, but we do not step down. Asthma treatment is a very typical example of this. As the patient is not controlled on asthma, we step up, and then patient remains on all those drugs forever. So you need to look at, can these be stepped down? Similarly, in epilepsy, we can add many anti-epileptic drugs, but then we need to look at, can any of these anti-epileptic drug can be withdrawn? So de-prescribing is a process. You need to look at these drugs properly. So now coming to the last part of my session, is the role of standard treatment guideline, how it can help you in promoting rational use of drugs. These are simple guidelines. The key feature of the STGs are they should be in simple language for priority healthcare needs. They should give you guidance on that, and drug supply should be based on STG, and this should be introduced. That's why these programs are being organized, so that these are introduced to you in your practice, so that patients get consistency amongst prescribers. The advantage is, otherwise, patients do a lot of medical shopping these days. They are not satisfied with one consultation. They may be approaching 3 or 4, and this their confusion increases as they increase the number of consultation. And because each one of us are giving our own opinion, and we differ with each other, this is called medical jostling. We don't agree with the other prescriber, and then the patients believe that, oh, perhaps I was consulting a wrong person. One of the example, very common example is, patient, I ask the clinician, why do you write antibiotics or Tiniba, or why don't you give ORS only, why do you give IV fluids to a mild dehydration patient? They say, patients come and demand for it. When you talk to the patient, you say, I don't know, the doctor never explained to me ORS. And even the second, when they consult the other person, because diarrhea has its own nuisance value, patients get worried as the number of stools increase, so they become very restless. they consult another one. The other one says, oh aapko ORS se kaise theek hoga, you need IV fluids. The other one says, oh khali IV fluid se kaise theek hoga, you need some antibiotic. So that's how, differing opinion about a disease leads to confusion amongst the patient. But if you are all talking about same language, ORS, because it is the dehydration which will lead to death, and rehydration is the only approach here. So standard treatment guidelines will tell you this, and the patients will get better supply, and you can concentrate more on the diagnosis part, because for treatment to be successful, you need to have a correct diagnosis. And with the heavy patient loads, with limited consultation time, it's not possible to have that kind of time. So you can spare some time for diagnosis, because treatment part is clear. You don't have to worry about this. STG, they standardize the treatment, they raise the standard of healthcare, they reduce the errors, best outcomes are achieved. It helps you in prioritizing treatment. I hope I'll just try to wind it up quickly. Dr. Dhamija must be waiting. We started, sorry, Dr. Dhamija, because we started late. STG helps you in prioritizing treatment. Many a times we know the treatment, but the prioritization is not done. Here is a case of a shock which comes to your emergency. This initial fluid bolus was given, and the order was correct. If you look at the technical part of it, the order is correct. But something is still missing in this. Had it been a face-to-face program, we would have had a good discussion on this. But what is it that is missing here in this management? You can write in the chat box. Perhaps it is the oxygen. Oxygen is the first thing. If a patient is having come to you in shock, the oxygen, the airway should be, breathing should be, restored as immediately. Rest all, IV line, diagnosis, history, investigation can be done once the patient, within 5 minutes of arrival, oxygen should be started. So STG will tell you what is the prioritization. Similarly here, antepartum management of a preterm labor, a typical textbook recommendation is like this. The first thing it says, embryo reduction in multiple pregnancy. Now my question to you, if it is if I have to tell you contextual recommendation, which facilities have this treatment option? So perhaps you have to look for other things which can help in preterm labor. Then these STG help you in standardizing treatment, standardizing the diagnosis, the cutoff points. You can imagine if the fasting and the PP sugar levels, if you tweak with the fasting and PP levels, many patients would be overdiagnosed, or the patient may be misdiagnosed. So STG help you in defining the criteria for diagnosis, and then they give you treatment according to this. So you can use this for consensus building, for screening. Then definitive directions are given. Very often you see textbook teaching, typically says you give slowly, give a bolus, or give a push. I'm sure even today, many of us do not know what is the difference between bolus and a push. What do you mean by give slowly? So you need to know, slowly over a period of 3 minutes, 5 minutes, 10 minutes, or 1 hour. So all these things are being taken care in the standard treatment guideline while they are giving definitive directions. The other advantages are that many of you are quality officers. You want to assess whether the prescription, the clinical inputs area of concern, whether the STGs are being followed, whether the supplies being made. So this can serve as a yardstick for you. So since this is a guideline, as the name suggests, it is not a law, but it is not good to deviate from the guidelines. We need to be looking at, be having a specific reason why are we deviating from the SDGs. Because it would be supportive, it will help you in the unfortunate event of litigation or the consumer compensation case. If you are following STG, the people get exonerated. I know of several instances where they quoted that they followed STG, they were exonerated. But you get into trouble if you are not following, and if you are not following and you do not have enough reasons not to follow, uh, then the courts take decision against you. So standard of care should be followed. Although from doctors, we are not expecting that they will be genius. We are expecting a standard of care will be followed by this. Okay, and proactive approach for follow-up should be followed. Courts have given decisions against the doctors, against the hospital, because they failed to follow up the patient. This is particularly important, stroke patients, the patients on retinopathy. This was the case. They had to pay because the premature child was not followed up for premature retinopathy, and also unnecessary prescriptions for antimicrobials, opioids, PPI, all these things. So all these things, there are many, what I was trying to communicate was, there are many different problems. We are all struggling to manage within our constraints here. So but standard treatment guidelines offers you many solutions here. It is good to follow. Somebody has already done that exercise, because there are hundreds and thousands of articles on the net. Somebody has already looked into it, critically analyzed, what is good, what is best in a current circumstances. And when we run this Google form in the beginning, now you could see it for yourself, how variations creep in a subtle manner. We didn't want to have a variation here, but because of our understanding, or because we were not able to update ourselves, because we were not exposed to these things, so standard treatment guidelines come as a handy intervention tool for you, which you can follow. This guidelines, we were the first one to publish it in 2002. We've been revising this, improvising, increasingly adding on to other diseases in this guidelines. These we try to give treatment here in brief, so that in your busy practice you could quickly recapitulate and follow. And the one of the unique features of this is that we give non-pharmacological treatment as well. Amongst the pharmacological treatment, very often we start the treatment, but we don't know how to assess response to treatment, how often to measure BP, how often to measure sugar. Everybody says 6 times self-monitoring of blood sugar, but is that feasible? Do you need to do it in all patients, or there are particular categories of patients where you need 6 times a day? Or pneumonia, we use it for x-ray. For diagnosis of pneumonia, we do x-ray at the beginning, but do we need end of treatment x-ray? So all these things are sorted out if you follow standard treatment guidelines. Somebody has already looked into it. The drugs are selected. We need to keep patients in mind, and there empower them. So patient education is one of the very important activity that we need to do it. In the book I showed, the standard treatment guideline, this is one of the US USP of this book that we give what to tell. Very often we don't know what to tell, what not to tell, and in our busy schedule we forget how to do it in a brief time that we have for consultation. So this can come to you handy, and dissemination and is very important. And with STG, you can bridge the gaps. You can reduce the practice variation, improve patient safety, knowledge translation, quality improvement. And because all this is necessary, because prescription is regulated by several laws, rules, requirements, standards. So we need to be complying with this. We cannot do it if we do not follow standard treatment guidelines. I think with this I will stop here. Sorry for keeping you waiting.
Thank you, ma'am.
Yes, I think I can stop share.
Can you hear me, ma'am?
Yes, I can hear you. How do I stop share? Where is that stop share?
Shall we go to next session, ma'am?
Yes.
Okay. Thank you, ma'am, for your very informative session on the standard treatment guidelines and its importance. Now I welcome Dr. R.K. Dhamija, Director, Institute of Human Behavior and Allied Health Sciences, New Delhi, to take over the session on key epilepsy management issues, do's and don'ts. Over to you, sir.
Good afternoon, everyone. I hope I'm audible. Am I audible?
Yes, sir.
So good afternoon, everyone. And at the outset, thanks for having me in this important session. Thanks to NHSRC and thanks to Dr. Sangeeta Sharma for inviting me and giving me this opportunity to talk on a very, very pertinent topic today, which is very common in our country, and there's a huge treatment gap in the field of epilepsy. So there are more than 1 crore patients of epilepsy in India, and 75% of these epileptic patients can be treated with the medicine alone. But unfortunately, there is a huge treatment gap, and many of these first-line basic drugs, we are struggling to make them available to every nook and corner in the country and to each and every patient. So that is something which we need to build upon, and this kind of sessions and this kind of NHRC's initiative will go a long way in providing the accessibility, affordability, and availability of the drugs to the patients who suffer from epilepsy. So my job in next half an hour is to run you through the key principles of management of a patient with epilepsy, and what are do's and what you don't have to do and which should not be done. So that's what we are going to talk about in next half an hour. So we will be talking about basically 2 things. One is what is epilepsy, how we define the epilepsy. There is a lot of different and misconception about the epilepsy. There's a lot of stigma associated with this disease. There are different kind of modalities of treatment available in particularly in a country like India, where we have multiple systems of therapies, whether allopathy or Ayurvedic or Unani or all these things. Because of the stigma involved, people go from one person to another person, one doctor to another doctor, and one specialty to another specialty. Many of these patients are being looked after in general practice, in the CHC level and the district level, and some of them are looked after by neurologists and a few in the psychiatry also. So my strongest belief is that the epilepsy can be managed at the district level or at the CHC level. Most of these patients can be managed very well, with sometimes with a few referrals to the tertiary care centers, in particularly in the drug resistance epilepsy or epileptic patients who are not responding to more than 3 drugs at a time. So these patients do have some other secondary cause, and we need to find out the cause and then treat accordingly. I would also discuss in detail about the management of epilepsy, including the status epilepticus, which you might encounter sitting in the peripheral hospitals. So what is epilepsy and how we define epilepsy and how it is different from the seizure? So seizure is an isolated event. It could be just one episode of loss of consciousness, or it could be tonic-clonic seizure, or it could be akinetic seizure, or it could be seizure associated with hypoglycemia or hyponatremia or hypocalcemia. All these metabolic regions could lead to a seizure, while epilepsy is actually a two unprovoked seizures which are 24 hours apart. So that is very, very important. So number one, these are the more than two seizures or two seizures. Number two, more than 24 hours apart. And number three, they are unprovoked. So obviously, recurrent unprovoked seizures is epilepsy. So that's basic definition of epilepsy, that these seizures are recurrent and these seizures are unprovoked, and they don't have any underlying metabolic cause like hypocalcemia or hypoglycemia or hyponatremia, or infections like meningoencephalitis or acute episode of neurological dysfunction leading on to seizure. Maybe a stroke presenting with seizure, that is not an epilepsy. Maybe a intracerebral hemorrhage presenting with seizure is not an epilepsy. So epilepsy could be secondary epilepsy, of course, could be due to regions secondary for which the patients can have seizures. But idiopathic generalized epilepsy, we always define like recurrent unprovoked seizures which are 24 hours apart. So what causes seizures? What causes epilepsy? Again, coming to molecular level, there are electrical changes in the brain. We all have fixed number of neurons, and neurons communicate to each other via neurotransmitters, and there is electrical transmission or electrical charge on these neurons. And when this charge becomes deranged or there is an excessive, it causes a seizure. It could be sensory seizure or it could be motor seizure. Motor seizure is usually convulsion, which we normally see, which is a common bread and butter kind of a presentation in the OPD or usually in the emergency, or sometimes by the time the patient is brought to the emergency, the patient becomes all right. So these are episodic neurological dysfunctions due to derangement of electrical charges or something like we encounter in our homes like an electrical spark. So there is a normal phenomena of electricity being transmitted in the wires, or the communication between the cells is through the electrical charge. So when these excessive charge is there or excessive electrical activity is there, it causes seizure. So normally there could be subclinical seizures or uh, cortical seizures, which is basically electrical phenomena, which is minor electrical derangement. But when this becomes very large over an area of say more than 6 centimeters square in the cortex, cerebral cortex, it causes overt seizure, which we see as a convulsion. So remember, seizure is not an epilepsy. When the seizures become recurrent, they are unprovoked, then we label the patient as an epileptic or an epilepsy. And then we try to find the cause, or we try to classify the epilepsy or epileptic syndromes or seizures. So this is broadly International League Against Epilepsy classification of epilepsy, which is followed all over the world. And this is a standard pretty much known to everyone. Seizures could be either focal seizure or generalized seizure, or unknown kind of a semiology. But the epilepsy as such types could be focal epilepsy, or it could be generalized epilepsy, or it could be combined generalized focal or focal onset generalized epilepsy, or it could be unknown again when there's a unknown timing or unknown, there's no witness, and we don't know exactly what happened on the field or what is the semiology. So remember the epilepsy types, remember the seizure types, and remember the syndromes. So there are syndromes, is particularly when these two or three features combine together and there is a underlying cause. So that could cause a epilepsy syndrome, which I'll come to later on. The syndromes could be very well defined, occurring in different age groups, having different etiology. So again, coming to the causes of the seizures or the epilepsy, etiology, it could be structural causes in the brain, could be congenital or inherited, where there is a cortical dysplasias or focal malformation of the cerebral cortex, or agenesis of corpus callosum. These are structural lesions. Similarly, acquired lesions could be there. There could be a brain tumor or a CNS tumor, what we call SOL, space occupying lesions, which can cause again a epilepsy or a seizure. Again, genetics, as I said, idiopathic generalized epilepsies, some of them are genetically inherited over the generations. Then it could be infectious cause like tuberculosis meningitis, infections like neurocystic cirrhosis or tuberculomas, very common in our country and some of the Latin American countries, where we get a lot of neurocystic cirrhosis patients coming presenting as a seizure and epilepsy later on when it becomes recurrent. Again, I told you metabolic causes of seizures. Always rule out hypoglycemia, hyponatremia, and hypocalcemia when a patient or first time seizure comes to you. It is important to know these because these are treatable conditions. So we can treat them, we can find them. These days, a new term, autoimmune epilepsy, has come up where we get autoimmune regions for the causes for the seizures or epilepsy again. So these are the main broad etiologies of the seizures. So it could be, causes of say intracerebral hemorrhage or intracerebral ischemic stroke. But when these becomes recurrent and they have a cause, we call them secondary seizures or symptomatic seizures, and then it can lead on to epileptic syndromes or epilepsy. So it is important to know what is seizure, what types of seizure it is, what is epilepsy type, whether it is focal epilepsy, because the treatment is also different. For example, the anti-seizure medication for focal epilepsy is different from the generalized tonic-clonic epilepsy or the focal onset generalized epilepsy. So obviously, it is important to know from the clinical presentation as well as from the investigations like EEG, which can guide us whether the patient is having a focal epileptic type of syndrome or it is a generalized epilepsy. So it is important to know that. And this is the classification which I just mentioned. So this is again another table as per the age group. So it is neonatal period, which one can have a congenital maldevelopment, birth injuries, asphyxia, anoxia, again hypocalcemia, vitamin deficiencies. Coming to infancy period, so there is a West syndrome, which is very common, which is also known as salam attacks. The patient has like this sudden myoclonic or sudden jerks, which are like salams. And then coming to the early childhood, 6 months to 3 years, again infantile spasms. Febrile convulsion is another important entity where the child gets seizures in a high-grade fever, which usually lasts up to 6 years of age. So it is important to know that it is a benign condition. Sometimes it can lead on to epilepsy later in the life. But it's always better to know whether the patient had a febrile seizure in the past or during the childhood. That becomes a risk factor for developing epilepsy in the later age. Again, coming to 3 to 10 years, again, some of the birth injuries, some of the infections, and then some syndromes like LGS or Lennox-Gastaut syndrome. And then something called Rolandic epilepsy or centrotemporal epilepsy, which is again a benign syndrome, but we need to know because it does not need long-term treatment. So febrile seizures as well as the Rolandic epilepsy, these are the conditions which generally do not require long-term anti-epileptic medication. So it is important to know because this happens in the childhood period and or an adolescent period. So obviously we need to know the cause and treat accordingly. Coming to the adolescent, which is the most common, is usually there is bimodal peaks. Either the seizures or the epilepsy happens in the early age of the life, say up to 20 years, or it is more common in the elderly after 60 years of age. So any regions are different. For example, in elderly age group, the post-stroke or the vascular seizure regions are more common. In the early childhood, adolescent, it could be idiopathic, including generalized tonic-clonic epilepsy or idiopathic generalized epilepsy, or myoclonic epilepsy. Similarly, juvenile myoclonic epilepsy, which is a very typical syndrome diagnosed not only clinically by the early morning jerks as well as the tonic-clonic seizures, or in the EEG, typical EEG findings are there in these patients, which can guide us to whether the patient has got a juvenile myoclonic epilepsy, because the JME or the juvenile myoclonic epilepsy is a condition where most of these patients will require lifelong treatment. So we need to know whether the patient has a JME or patient has a idiopathic generalized epilepsy or patient has one of these syndromes like Rolandic epilepsy or the febrile convulsions. LGS, Lennox-Gastaut syndrome, is a condition again which is sometimes difficult to treat and requires many drugs and long-term management. not only the medication, sometimes we need neuromodulation and other types of treatment like ketogenic diet and other things for that. For the sake of the today's presentation, we will stick to the more common syndromes like JMEE, which is very, very common, idiopathic generalized epilepsy, and epilepsy because of the infections or vascular lesions or vascular regions. So that is something which we need to remember. The other thing which I need to tell the audience is that any seizure happening after 35 years of age has to be taken very seriously. So usually these patients have underlying structural pathology in the brain in terms of either SOL or in terms of something else going on. So one has to be very careful if the patient has a first time seizure in the adulthood or after the age of 35. So that is something carry home message I want to give it to you. So this is broadly the definition, types, and all these things. We will come to the epilepsy and the pregnancy later on in this presentation, and we will cover in that context of epilepsy. So usually either you are sitting in the OPD and you get the patients and you have to treat them, or the patient lands up in the emergency with status or with recurrent seizures, which are not, patient is not gaining consciousness or patient is throwing fits multiple times in a short span of time. So outpatient clinic, these patients normally can be treated, most of these patients, if you have the optimum management. So the questions which usually one needs to ask: when to start the anti-seizure medication, what are the initial drugs, what to monitor during the treatment, and when you get the breakthrough seizures, how to and when to escalate the treatment or add the drugs or increase the dose, what to do in pregnancy and breastfeeding or any other similar situations, what are the guidelines for investigations or management, including this, and when to stop medication. So obviously, these are the questions which need to be answered. And in addition to these, I would also like to add driving and epilepsy, marriage and epilepsy. These are two conditions which are always important when you are managing the patients with the epilepsy. So seizure with the status epilepticus, if they land up in the emergency, they will always require the treatment right from the beginning. Okay. Patients like intellectual disabilities or anoxic birth injuries or cerebral palsy, or patient of seizures with some neurological deficit. So these are very, very important. So when we see the patient, we always try to see whether the patient has got a risk factor for developing epilepsy, or when the patient needs treatment, or when the patient needs long-term investigation, monitoring, and follow-up. So any patient who has got a history of family history of seizures, any patient who has got a head injury, any patient who has had a episode of meningoencephalitis or tubercular meningitis in childhood, or a long-standing febrile illness, any patient who has got a any structural problem or structural lesions in the MRI or in the CT scan, any patient who has got an abnormal neurological examination or abnormal EEG. So these are the indications when we definitely start the treatment. Otherwise, any patient who comes for single seizure in the OPD, if a patient had a seizure a couple of days back, a single seizure, we don't start treatment in all the cases. We always, take a joint decision, shared decision with the patient and the family, and explain to them that this is single seizure. This is still not called epilepsy. If they want to wait, ideally they should wait. They may not have a seizure later on, and if they have the seizure, we will have to start the treatment. A single seizure does not require a everyday medication for next 3 years because some patient had a seizure or a unexplained loss of consciousness or a fall. So obviously you need to find out these patients, you need to follow them up and monitor them. In case they develop another fit or they throw another fit or a seizure, then obviously it becomes a recurrent unprovoked seizures happening 24 hours apart, and that fulfills the criteria of a definition of a epilepsy. So single seizure may not require treatment, but if single seizure is associated with risk factors which I enumerated now, like head injury, previous head injury, or a previous risk or a family history, or a abnormal EEG or abnormal imaging finding, or infectious in the past. So obviously then patient needs to be treated even if patient has a single seizure. Sometimes your occupation or a profession also may be highly demanding, like pilots and drivers. Obviously, they also need to be treated even if there is a single seizure. Sometimes we get a lot of alcohol withdrawal patients, or alcohol as a dual-edged sword. Alcoholic intoxication also, patient can present with seizures, and alcohol withdrawal also, patient can present with seizures. Obviously, these patients sometimes need treatment, but we need to find out the associated metabolic conditions. It may be syndromic feature of a underlying metabolic cause. Uh, many like Korsakoff or Wernicke's encephalopathy. These patients with a background of alcoholism will come to the emergency with a seizure, and then you need to weigh whether this patient requires treatment or not based on your clinical judgment as well as the imaging finding as well as the EEG. As I said, single seizure with no focal signs can wait, but decision rests with the patient. So it's a joint decision when to start the treatment. And normally we discuss with the patient. Some patients are even not comfortable even with single seizure. Say a patient in a social environment or a high pressure job, they may not like to have another seizure at all. So these patients may require treatment and may ask for the treatment as with the shared decision with the treating clinician. So what drug to start? So it's a very good question, and it all depends on the type of seizure, as I said, whether focal or generalized, and also the age of the patient. So these two things are important. So before that, I just wanted to tell you also the indication for imaging and indication for EEG. Maybe I'll touch upon it a little later. But as I said, the type of seizure is very important, and the age of patient is also important. So this for the adult population, for the epilepsy, as I told, there is 1 crore people living in India with the epilepsy. So obviously there's a huge number, and we need to treat them to improve their to make them symptom free or seizure free, as well as to improve their quality of life. So the first or the initial choice in a generalized tonic-clonic seizure, generalized epilepsy, would be either valproate or phenytoin or levetiracetam. So during now, these periods we are using more often levetiracetam and valproate as a first line treatment, and many countries are not using phenytoin now because of the side effects associated with phenytoin, which are mostly cosmetics and hematological. So if many countries can afford to just start with levetiracetam and valproate, but in our country, being the cheapest drug, being the easily available drug, and accessible, the phenytoin is still the first line of treatment in many patients in our country. For focal, of course, the carbamazepine or phenytoin both are useful. Carbamazepine or oxcarbamazepine is preferred drug if the patient has got a focal seizure. You can also use lamotrigine or lacosamide, but lamotrigine is again a first line drug for generalized as well as the focal epilepsy, but lacosamide and the other drugs, they are add-on. So valproate, levetiracetam, carbamazepine, these are the drugs for the focal epilepsy. Again, levetiracetam, phenytoin, and valproate, these are the drugs, including lamotrigine in a particular population in females, very good drug. So these can be used as an initial drug. We always start monotherapy to begin with, take it for the full dose and then wait. And if still the patient is throwing seizures and the epilepsy is not controlled and there is no structural lesion, then we add on the second drug. Similarly, build down the doses to the second drug to the maximum before adding to the third drug. And if the patient does not respond to the combination of 3 drugs, we call it a drug-resistant epilepsy, and then refer it to the highly specialized center for optimization treatment or further intervention in terms of neuromodulation or epilepsy surgery in selected patients. In absent seizures, again, valproate is the most useful drug. Earlier, we used to have ethosuximide, which was again discontinued, but again, in recent years, ethosuximide has been made available in our country. But valproate remains the drug of choice in absent seizure, where the patient gets a staring spells for 10 to 15 seconds. These are the children in the classroom or in the playground or at home, which suddenly become still and staring look, unresponsive to the stimuli. But these are very short lasting and they have a very typical EEG of 3 hertz per second and very easy to diagnose. As I told, in the emergency, patients with this status epilepticus also come, and we will deal it separately. So broadly, generalized epilepsy, tonic-clonic seizure, you use levetiracetam, valproate, phenytoin. For focal, you use carbamazepine, levetiracetam, phenytoin, lamotrigine, which can be used in both epilepsies. And absence seizure, valproate is the drug of choice. In children, again, generalized tonic-clonic seizures, carbamazepine and valproate can be used. And myoclonic, particularly myoclonic jerks or seizures, valproate and levetiracetam. Absence is always the valproate or ethosuximide. Focal seizure, carbamazepine or phenytoin or valproate, both can be used. In patient of less than 1 year with West syndrome, either ACTH or vigabatrin, later on second drug of choice is valproate. LGS, the valproate is the first drug of choice, but these are the patients which need to be referred to the higher center in epilepsy clinics or services which are running epilepsy, higher level of treatment and higher level of interventions for the patients, because these are the syndromic diagnoses which need specialized investigation and then management accordingly. So as I said, commonly you use the valproate as a first drug, whether it is focal or generalized, in addition to phenytoin and carbamazepine or lamotrigine. But in women of childbearing age, you should always consider levetiracetam. Many of these patients, still women will have the valproate as a first line drug, and valproate is known to cause fetal neural tube defects. In 5% of the pregnancies, normal pregnancies will have 2% of neural tube defects, but epilepsy and valproate combined will have double the frequency or double the risk of having the children born with the neural tube defects. So obviously, valproate has to be avoided in patients who are likely to become pregnant in a childbearing age. And in case the patient is already on valproate, you can continue with valproate in case the patient is well controlled and is less than 700 milligram valproate. Anything more than 700 to 1000 milligram is known to cause at least double the risk of neural tube defects. But generally in practice, if the patient is taking valproate and becomes pregnant and the dose is less than 700 milligram and patient is not throwing fit, we don't discontinue treatment and continue with that. In case patient is planning to become pregnant and there is preconceptual counseling, then we try to change the drug valproate with either levetiracetam or lamotrigine. So always remember, pre-pregnancy counseling or consultation, try to change the valproate to one of these two drugs, levetiracetam or lamotrigine. But in the patient, in the case scenario, the patient is taking valproate and becomes pregnant, then you have to continue if less than 700 milligram or change it to the lamotrigine or levetiracetam if the dose is higher. So that is a rider to the valproate. Otherwise, it's a very good broad spectrum anti-seizure medication, can be used in all types of seizure type, whether myoclonic or focal or generalized and or absent seizures. So what to monitor? So that is very important. When you put a patient on anti-seizure medication, after investigation, EEG and MRI or CT scan or metabolic baseline profile, then you either ask the patient to have a seizure diary, where the patient can come up with the time and date of seizure or breakthrough seizure, and accordingly you can optimize the treatment, or you can also monitor, and also you have to monitor the progression of illness if there is a secondary cause of seizure or epilepsy. Adverse effect of the drugs is very important, particularly when the patient is on phenytoin, where you can have a gum hemiplegia, hyperplasia, or you can have megaloblastic anemias, or you can have rash. Rash is very particularly commonly seen with carbamazepine or phenytoin, and we have seen patients landing into Stevenson-Johnson syndrome after this the treatment with carbamazepine or even phenytoin. So do remember, the first few months, the patient develops any kind of a rash. Rash is also very common in lamotrigine. So one of the side effects of lamotrigine is a skin rash, and we need to tell the patient to be vigilant about this skin rash after starting lamotrigine. Similarly as carbamazepine or phenytoin. So these are very important, and patient needs to be told about, particularly, for example, valproate. Valproate will cause some hepatotoxicity, some tremors, some obesity, again, hair loss and weight gain, so obviously leading even on to metabolic syndrome. So if the patient is a female or a girl, obviously these are important for her social life and for her general well-being, and these things have to be told and given a choice of other drugs like levetiracetam or lamotrigine if the patient is continues to have seizures and epilepsy. Therapeutic drug monitoring, TDM, is again one aspect of management of epilepsy, particularly phenytoin and carbamazepine and valproate. These three drugs are commonly used for drug levels, and there are some specific indications. We don't use these drug levels for every patient, but the patient, if there is showing the toxicity or patient is having a problem with the compliance where you think the patient is not taking medicines as prescribed, then you can always ask for the drug levels, particularly patients of, say, valproate toxicity or phenytoin toxicity or carbamazepine. Either ways, either suboptimal therapeutic effect or toxic level. Sometimes the drug levels are also indicated in pregnancy and with the hormonal changes and with the if the patient is on oral contraceptives, because the drug levels of the anti-seizure medication will fluctuate if the patient is at the similar time on oral contraceptives, particularly in the case of lamotrigine and levetiracetam. But we don't use much of levetiracetam drug level. The more important is the phenytoin, carbamazepine, and the valproate. So as I said, these things not routinely done, but certainly despite appropriate dosing, the patient is not showing response, suboptimal level, or patient has a compliance issues, or you are suspecting a drug toxicity. So when to add on or when to escalate? So that is again important. The protocols are there, the guidelines are there. Indian Epilepsy Society has guidelines, the NICE guidelines in American Academy of Neurology. All these are available on net free of cost and very, very useful resources when you're dealing with a patient with epilepsy. Always start with the monotherapy, add second drug only when the maximum dose of first drug. Try to withdraw the first drug if the seizures are controlled with the second drug. And if the two drugs, appropriate seizures for the seizure and maximum dose, seizure are not controlled, add second line or third drug, or consult epilepsy specialist or a neurologist and send the patient to the tertiary care center to find out why the epilepsy is not controlled, if there is any structural reason which can be removed, or there is higher level of treatments like I said, vagal nerve stimulation or neuromodulation or the ketogenic diet or things like that can be given to the patient. So two important aspects of women with epilepsy. I know there are questions in the chat box dealing with the seizures in pregnancy or particularly somebody asked about the breast or the eclampsia. So when this patient in a childbearing is having epileptic seizures, always consider levetiracetam as a first drug of treatment. If the patient is in the childbearing age and patient can afford and it is available, try first line as a levetiracetam. And otherwise, valproate is also used commonly, but valproate has a double risk of neural tube defects, as I said. Prefer one drug, single drug in the pregnancy, that also at the lowest dose. So avoid multiple drugs if the patient is trying for pregnancy or patient has become pregnant. So in spite of these medication, if the seizures are there or the patient has seizures during pregnancy, add on lamotrigine to the existing drug and try to see if the patient can be controlled and later on a monotherapy. Usually all the deliveries end up with a normal delivery or normal pregnancy without much of problem, as we use the either the valproate less than 1000 milligram or levetiracetam or lamotrigine, or even as we go through the course of pregnancy in the first trimester, second trimester, and third trimester. So how to predict or how to diagnose antenatally if the child or the fetus is going to have a neural tube defect? So there is a protocol for all the women who become pregnant are on anti-seizure medication. Always do two ultrasound, level 2 ultrasound one at 16 weeks and one I do it at 20 weeks. And we always get alpha fetoprotein levels at 12 weeks of pregnancy. So these two things have to be done if the patient is pregnant and is epileptic. So AFP level at end of the first trimester and level 2 ultrasound at 16 weeks and 18 weeks. So these are some of the guidelines during the breastfeeding, what kind of treatment, what kind of recommendations. Most of the anti-seizure medications are safe during breastfeeding, except for these older generation like phenobarbital and all these drugs. And there is something, some literature on cognitive development, development of cognition of the child if the patient had anti-seizure medication during pregnancy or childbearing age and the during the breastfeeding. The field is still evolving, the jury is still out, so we are not still sure whether these cognitive effects are seen in all the patients, but we do see some literature coming up, and there is some evidence that these drugs, particularly valproate, and these drugs can cause later on cognitive dysfunction in children born out of patients who were pregnant and anti-seizure medication. Another thing is, I just wanted to add to the levetiracetam with the mood issues, with aggression and all these things can happen with levetiracetam. And if the patient is developing aggression or behavioral side effects on levetiracetam, you need to either reduce the dose or to switch over to the lamotrigine or other broad spectrum anti-seizure medications like valproate. Lastly, when to investigate, what to investigate. So usually the imaging is not done in all the epileptic. There is certain indication when you do imaging. EEG is done usually if the patient is first time seizure. Try to get the EEG as early as possible. If the patient has shown a fit today, try to get within 24-hour EEG. That is likely to show that is likely to yield more EEG finding if you delay the EEG. Sometimes the EEG will not yield anything because interictal period EEG, like the EEG done between the two seizures, there are 30% chances. If you do it sleep deprived EEG, the chances becomes 50. If you do repeated EEG, the chances can become to 70%, showing something. So EEG can guide you with the type of seizure, type of epilepsy, and selection of medication. EEG can also guide you when to stop the medication, which I'll tell you. If there is a normal EEG after 3 years of seizure onset or 24 months of anti-seizure medication with no seizure, normal EEG, normal neurological examination, one can consider tapering of the anti-seizure medication. So these are, I said, the indication for MRI or CT scan if you are suspecting a tumor like late onset epilepsy, or alcohol withdrawal, or a patient of head injury. Sometimes patient of head injury can develop seizure. Sometimes patient with seizure can develop head injury. So patient had a seizure, had a fall, and then had a head injury. So obviously you need to be careful while evaluating, taking history. Patient having 60 years plus cerebrovascular diseases like strokes or tumor or abscess or degenerative disease. So these are the indication for MRI. Not every patient needs an MRI. Many of these idiopathic generalized epilepsy patients can be managed without any imaging unless patient is not responding to the treatment and you are suspecting a secondary cause like neurocystic psychosis or the tuberculosis or tuberculomas. Before that, I just need to also tell you if in our scenario, if the patient is having neurocystic psychosis, you also need to treat that infection with anti-helminthic drugs like albendazole. So there are different protocols, but what normally guideline says 14 days of albendazole 400 milligram twice a day. Before you start the albendazole, you have to start a short course of steroids, because if suddenly all these cysticerci are dead, they will create anaphylactic reaction and that can be fatal. So obviously, you diagnose cysticercosis, then you start on a steroid trial, a short course of steroid, 3 to 5 days, and then add on to the albendazole 400 milligram twice a day for 14 days. So that is the treatment for neurocysticercosis. And you also have to get a ultrasound of the eye, because cysticerci could be present in the extraocular muscle, and if they are present in those muscles, then their lysis can lead to again a vision loss. So obviously, these are the things which you need to carry on if the patient is having a neurocysticercosis. On the other hand, if the patient has got a tuberculosis or a neurotuberculosis, then the patient needs to be put on ATT for 12 to 18 months. So these are the guidelines. These are still evolving, but the cause of the epilepsy also needs to be treated. That's what I want to emphasize in addition to the anti-seizure medication. So anti-seizure medication are more of a preventive aspect of management of epilepsy, while the curative treatment of epilepsy, secondary to infections, tumors, or abscess or any other infection, is a condition which can be, which should be treated, and these patients can be cured. So when to stop? As I said, 2 years of anti-seizure medication with no seizure and normal EEG and normal neurological examination, you can consider, but you need to discuss again. There has to be slow tapering. The patient is not allowed to drive during the tapering of the medication. The patient is not allowed to go on heights or lifts or other similar conditions where he is likely to be vulnerable to injury and other things and causing injury to the other people also. So that is something which we need to tell the patient, and the tapering has to be done over a period of 3 to 6 months. Slow tapering, half the dose in first instance, and then accordingly 50% reduction in next 2 to 3 visits. There are chances, even if the patient is on an anti-seizure medication for 2 years with no seizures, normal neurological examination, normal EEG, normal MRI, still there are 30% chances of having a seizure while tapering the doses or tapering the anti-seizure medication, and that needs to be told to the patient. And in case the seizure happens, then the treatment has to be restarted, and probably then it will be a longer period of time, like even a lifelong. So that is something which we need to tell the patient. In certain specific conditions, like I said, juvenile myoclonic epilepsy, where patient has got seizures, generalized tonic-clonic seizures with morning awakening jerks or myoclonic jerks, patients with secondary gliotic changes, particularly with scars of previous injury, insult to the brain, or patient has had a withdrawal seizure, that means seizures during the withdrawal period. These patients should not be attempted withdrawal later on also. So that is something to remember how to taper. In addition, when I told you how to start, it is important to know how to stop also. So last part of the talk is about the status epilepticus and the new onset seizure presenting in the emergency. Obviously, there are protocols. The important thing in the district level is to know that the patient, when presents with seizures, should be first evaluated for ABC, that is airway, breathing and circulation, followed by blood glucose level, just for the so that patient does not have a hypoglycemia or even sometimes the hyperglycemia and ketotic comas. So always try to do a finger prick blood sugar levels, and then you can start with loading with phenytoin or phosphenitoin or valproate or levetiracetam, whatever is available. These days, levetiracetam is preferred drug, but in the remote areas, even phenytoin or phosphenitoin that could be used. But before that, we also use diazepam or not diazepam, the benzodiazepines, lorazepam, slow injections. Lorazepam is preferred over diazepam because diazepam is known to cause sometimes respiratory depression if you give it quickly. So if you have diazepam only, try to give it very, very slowly. If you don't have it and you have preferred the other drugs, better drugs like lorazepam, then you start with that. And if the seizures do not control, add these anti-seizure medications, levetiracetam or valproate or phenytoin. Always monitor these patients in the emergency for recurrence. These patients can have multiple seizures in a single day or a single first few hours. And as I said, be cognizant of the causes like hypoglycemia, hyponatremia, patient presenting with hemorrhage, subarachnoid hemorrhage, cerebral venous sinus thrombosis. All these patients can present with seizures, and these patients will also have some other neurological findings, sometimes with thunderclap, headache like subarachnoid hemorrhage or cerebral venous sinus thrombosis. So we need to be vigilant. We need to take a detailed history around the surroundings. We always ask the patient to make a video if the patient has a seizure outside the hospital, and these videos with the phone on the phone can be very helpful during the assessment. Check particularly in patients who are younger, children, the age group of the children. So check for the febrile seizure, check the temperature and any of the neurological deficits. So as I told you, status epilepticus is now defined as a status, refractory status, and the operational guidelines are there by 5 minutes, 10 minutes, and these have a very, very important implications in the management of status epilepticus. Sometimes, rarely, you need to intubate also and put the patient in ICU under anesthesia. The most common cause in Asia, as I told you, infections, trauma, all these things. We need to be vigilant and we need to know these. If the patient has got a late onset epilepsy, you need to be very, very careful about finding out a cause on the MRI. It could be stroke, it could be seizure, it could be abscess, it could be tumor, and other things, the old injuries and the other mitochondrial disease and rare diseases of the brain, which can present with the seizures. There are some neurocutaneous markers also. So while you take the history of all these risk factors, you tend to examine the patient, see for the skin markers. There are neurocutaneous syndromes, tuberous sclerosis, and all these syndromic diagnosis can be made looking at the skin only. And you should always be thorough in your examination, properly expose the patient, see if there are any tubers or any other skin markers to tell you what is the underlying condition. To summarize, for the status epilepticus, as I said, diazepam, lorazepam, or midazolam spray or the injection, and followed by the anti-seizure medications. As a second line, phosphoenitoin is better than phenytoin. It can be given in place of phenytoin because it does not cause quickly cardiovascular side effects. As you know, phenytoin is also used for arrhythmias. So you have to be very careful. It is also an antiarrhythmic and a pro-rhythmic drug, both ways. So we need to be very careful when we are using these drugs. We have to give it slowly. Again, levetiracetam about 2 to 5 milligram per kg per minute, and you usually give 1 gram or 1.5 gram in an infusion. Just to summarize what I have been talking in last 30 minutes is that valproate first-line drug can be used as a broad spectrum, except for the women of childbearing age, where you should always consider as a either lamotrigine or levetiracetam. Always try go slow and go slow, and try monotherapy as per the seizure type or epilepsy type as the initial drug of choice, and then build up to the maximum dose. If the seizures are controlled well enough, if not controlled, add second drug on a low dose and build up to the highest dose. If see the two drugs, try to withdraw the first drug if possible. Otherwise, continue with the two drugs. Even if that with two drugs the seizures are not controlled, then add on the third drug. And if the three drugs cannot control the seizures, then refer the patient to the higher center. Pregnancy, epilepsy is normal, like any normal pregnancy, except that you have to be vigilant about the anti-epileptic drugs, particularly valproate, and consider the alpha-fetoprotein levels at the 12 weeks of gestation and the level 2 ultrasound at second trimester, 16 and 18 weeks. Breastfeeding, safe, almost all the anti-epileptic drugs. When to taper, as I told you, after 2 years of anti-seizure medication with no seizures. Certain conditions like JME require lifelong treatment, and the secondary causes like old insult, cerebral insult will require long-term treatment, and any injectable can be given in this status epilepticus. Thank you very much for your attention.
Thank you, sir, for your detailed presentation on epilepsy, what it is, how to diagnose, and how treatment should be initiated, which drug can be given. I think the two most important challenges for epilepsy are, first is to diagnose, whether the patient is having seizure or not, and then to start the patient on the right anti-epileptic drugs. And third, then next is when to stop these anti-epileptic drugs. I think with this the session is open for question and answer. If you have any questions for the speakers, you can write it in the chat box. Today's session was focused on epilepsy. I think some of you were writing about seizures in pregnancy. That's related with pre-eclampsia and eclampsia, how to manage seizures. But today we really focused on the epilepsy part.
It's important to know the clinical features of eclampsia. if the patient is having hypertension, pedal edema, proteinuria, then throws a seizure, so becomes a part of the eclampsia. Sometimes the patient will have syndromic manifestations like posterior reversible syndrome press. These are the patients who are at a higher risk, particularly these patients are on sometimes drugs causing press or eclampsia causing press. So these patients can be diagnosed easily on a CT scan, and then the treatment remains the same. Only thing is you need to monitor after the delivery and get a repeat imaging done whether to see the lesions have disappeared or not. Hypertension is one reason for these patients, whether eclampsia or press, in addition to the other conditions or other risk factors, including drugs and including conditions related to pregnancy, such as eclampsia.
Sir, can you, very often people ask this question, people, especially sitting at the periphery, they get, too much, intimidated by the seizures and they want to refer. Can you suggest, tell us about what is the, at-home treatment they should be educating their patients, and what should be done during transport of these patients? To, if required, to a higher level.
Thank you, Dr. Sangeeta. This is a very, very pertinent, important topic, particularly when the audience is from the peripheral areas. So the first aid during a seizure is very, very important. And we are trying to educate the public and the bystanders how to manage or the family members when the seizure happens at home. The first thing is that you need to keep the patient in a lateral position. So obviously, keep the patient on a lateral position. Do not force anything. The generalized tonic-clonic seizures will have it, grinding of the teeth or the, tongue bite and all these things. Do not try to force a spoon or anything, in the mouth of the patient. Just leave it. All these seizures will happen only for 1 minute. The any seizure happening more than 2 minutes, we usually think about the diagnosis. Is it really seizure or it is hysterical or non-epileptical psychogenic phenomena? So seizures will be there only for 1 to maximum 1.5 minutes. So remember that is important thing to know. And during that 1.5 minute, patient will have a deep breathing, patient will have a frothing from the mouth, patient will have a jerking movements of the limb, patient will become, a little bit altered sensorium or unconscious for some time after post ictal phenomena, what we call, and after half an hour to 1 hour, patient will become normal. So this is the time when we want to avoid a head injury, avoid an injury to the patient, and let the patient pass through 1 minute of this seizure. And if you have a midazolam spray at home, so best is to use that spray, intranasal spray, give it to that, and that should be okay to abort the seizure. So abortive therapy at home is usually the midazolam spray, but in the hospital you have injectable anti-epileptics after making initial assessment of, as I said, ABC and the metabolic baseline profile. So always remember 1 minute seizure, try it in the lateral position, do not force anything to the mouth, use intranasal midazolam spray if it is possible, and try to avoid injury like a hard surface or things like that.
Another, question, very often, when a patient is newly diagnosed as epilepsy, parents are usually very much concerned. So they ask, whether the child can go to the school, can do cycling, or can go to the rooftop, or can be doing swimming. So how, when can a child can resume these activities when he's on anti-epileptic drugs?
So obviously, a patient on an anti-epileptic medication needs to be careful in the initial 3 to 6 months when the patient is likely to throw another seizure or recurrent seizure. If the seizures are controlled, then patient can resume the normal schooling and the normal activity, but still contact sports are avoided. For example, boxing and other things which are high risk. Patients should avoid swimming alone, or I don't allow my patient to go for a swimming at all, because that's a very, very dangerous if the patient has a tendency to throw seizure. Otherwise, the going to the heights and going to the other activities, one can resume it after the seizures are controlled in 3 to 6 months' time.
Sir, there is one more, a very common query people have. Although you have covered, what all medicines, anti-epileptic medicines can be given during pregnancy and breastfeeding, but very commonly they have a question whether, they should go ahead with, if it is a marriageable age, women, whether they should, marry it or not. Very often it happens that they don't disclose this to the spouse's family, and very often anti-epileptic drugs get discontinued because they haven't disclosed this. Can you elaborate on this, how to tackle this problem?
So this is more of a social problem rather than a medical problem. Any girl, as I told, normal pregnancies, normal happy married life with epilepsy, with anti-seizure medication, this should not be a problem. This is any other disease, like any other disease of brain or some people would have a diabetes, some people will have a hypertension. So some people will have an epilepsy, which is a treatable in majority of the patients. So one should have a counseling sessions before the marriage, and how to, uh, things like oral contraceptives and things like, planning pregnancy. These things have to be discussed, but hiding or not telling the spouse or the family or the other family is not advisable, because it's the social occasions, the patient can have a seizure, and that could be embarrassing, and that could lead to the other disputes and other things. So it is always better to clarify. If in case of any doubt, let the family talk to the neurologist or a physician who can very well explain to both the families about the implication of epilepsy in the married life, which is almost like a normal married life. So obviously, these girls have a normal life, and they should be not be afraid of telling anyone in the family about hiding or not telling, and taking medicines without the knowledge of the family. So it's something more of a social problem, and we should always educate the masses, and tell that this is something which can happen after the marriage also. Seizure can happen, or a newly diagnosed epilepsy can be there after the marriage.
So there is a question in the chat box. Epilepsy in aged above 60 years with hypertension. Medicine to be continued for how many days after patient is stable or there are no seizures? Dr. Smith.
Yeah, so this is again, a very important question, because elderly patients, even a single seizure can lead to a fall, can lead to a hip fracture, can lead to a subdural hematoma. So these are the things which we need to avoid in an elderly population. So in case the patient is having a recurrent seizures, the treatment needs to be long term. So long term means it could be lifelong also. Just to be on a safer side, because all these anti-seizure medications also have side effects like osteoporosis or bone or impaired bone health. So these medications need to be given the calcium supplements. Similarly, the young women always have to be given folic acid with the anti-seizure medication. That is something I need to stress upon. With the anti-epileptic drugs, you need to add folic acid, just 5 milligram folic acid, in addition to calcium supplements and vitamin D supplements. So only these two things remember. In elderly population, you need to look upon the bone health, and along with the anti-seizure medication, long term, because single seizure can be fatal. And in women of childbearing age, with the anti-epileptic medication, please add folate in all patients along with calcium supplements.
Sir, I think you have answered this, but there is one question in the chat box. If seizure free for 2 years and on medication, what about driving?
So normally, the driving is a legal issue. So it is, depends on areas to areas. But in India, the driving laws are still not very clear for the epilepsy patient. So we are trying to formulate. The general consensus is that if the patient is seizure free and is compliant with the anti-seizure medication, he is allowed to drive.
There is a question about if a 2 years child have had high grade fever.
I just need to clarify, when I'm talking about driving, I'm not talking about the commercial driving.
Okay.
So commercial driving is when I'm driving a bus with 50 people on board. And this driver, if he throws a fit, he's putting the 50 people at risk of an accident, and as well as other people on the road or other road users, something like that. So commercial driving, no, even if the seizures are controlled, the private or the personal driving, depending upon your control of your seizures and your other causes and other factors associated with epilepsy.
There is a question about a 2-year child has having high grade fever. Can he or she present with seizures?
Yes, that's what I told. The febrile seizures usually happen up to 6 years of age with high grade fever. So these children do not require anti-seizure medication. They just required paracetamol or acetylsalicylic acid or the treatment of the fever, the high temperature, whether cold sponging or avoiding of having a high grade temperature, so that the patient does not throw a seizure. So that is something we need to keep in mind. And usually these children will not throw seizures even with fever after 6 years of age, although it remains a risk factor for developing epilepsy in the later years of life.
How can you throw some light on how to prevent these febrile seizures?
So just to avoid children having high grade fever. So the patient is having 99, 100 fever, just try to give paracetamol immediately so that the fever does not go beyond that. So just avoid that, keep a cold sponging and look for this, why the patient is having fever. So obviously the underlying condition, fever is just a symptom. There has to be some other infection or some other reason for the fever which needs to be treated so that the patient, the fever can be controlled. Otherwise, you will keep on giving the paracetamol unless you know the diagnosis of the region, whether it is viral or dengue or malaria or anything like that.
I think there are no more questions. If there are any questions, I think we have taken.
I've written my email. For any of the participants who has any query, can send me the email and I'll try to answer the query.
I think there are no more questions in the chat box, and we must thank you, sir, for such an elaborative session and taking up the questions which are, regularly people are facing and they don't know where to find the answers, and that coming right from an expert like you who are dealing with the epilepsy patient day in, day out. I think our participants today must have got benefited and they will find it useful. Next time when they see a epilepsy patient, they'll be much more comfortable in managing those patients. Very often these anti-epileptic drugs are provided at the lower level, but since people are not very comfortable with dealing with these antipsychotics, antidepressants and anti-epileptic drugs, very often patients are suboptimally treated. At least if epilepsy is diagnosed by a specialist and treatment has been initiated at a specialist level, people sitting in the periphery, CSC district hospitals, they can continue to monitor these patients well and maintain treatment, and so that epilepsy is well controlled. I think with this, should we close the session today? Thank you once again, sir, for taking out time. And today, he had a exam going on, and I don't know how have you taken out time to come out here. And I think you sat through all the session here. For throughout the session. Thank you very much, sir, for coming up and despite your busy schedule, you could take out time for our participants here.
Thank you.
Thank you, ma'am. Thank you, sir. Even on behalf of NHSRC and DSPRD, we thank for you for a very informative session on key epilepsy management issues. I also thank to all the participants. I hope all get the benefit of this. And even sir has mailed his personal mail ID so that you can query the questions. And regarding any certificate issues, I have shared the mail ID stg.webinar@nhsrcindia.org. You can mail there also. And I also thank to supporting for conducting this session on every month from behalf of NHSRC for DSPRD also. And also thank to Major General Professor Atul Kotwal sir and Dr. Jain Srivastav sir for supporting to take this session. Our next session is on 17th December of 2022 on chronic obstructive pulmonary disease, that is COPD. Link will be shared to you through your mail ID by just a week ago of the session. Hope all have got this use of the epilepsy session benefits. And any queries, please mail to the stg.webinar@nhsarchindia.org. And YouTube link has shared in the chat box. Within 1 week, you will get this session YouTube live. Yes, ma'am.
Annapurna, there were questions in the chat box about the certificates for the previous sessions.
A previous session has done from ECHO side. They have some issues with ECHO, ma'am, that we are sorting it out. Once it gets sorted out, we will share with them.
Okay. When do they expect certificate for this session?
Actually, अभी ECHO से कुछ country पूरा से वो meeting चल रहा है, ma'am. Some meeting is going on with them.
Yeah, Annapurna, this
So
one is
maybe by week end, by this week, next weekend, they may get it, ma'am.
Okay. This one is from WebEx, so you would be issuing.
This one is from WebEx. This is from our side. By within next Wednesday, everyone will get the certificates. Like
Sir,
who has attended pre and post test.
Sir, can you write your email ID again? Some of them are asking for. I hope see you next month for COPD.
On 17th December 2022.
Yes. Please disseminate the word, and we would be happy if more and more people are able to join and get this benefit. Under NCOA's scheme, clinical inputs is a very important area of concern, and one of the standards says whether the standard treatment guidelines are being followed or not. So I think this is one occasion where you can get sensitization to this, and above all, you meet the expert who is talking to you about the disease, and he gets into the details. I know people, those sitting at the periphery, they don't get much opportunity to upgrade their education. So this is one opportunity I think all of you would like to avail. With this, I think I'll close this session. Thank you all once again for coming and participating in the program. Thank you, Dr. Damija, for coming in and sparing time for the program.
Thank you.
Thank you, sir. Thank you, ma'am. Thank you, all the participants.
You can close the session, Annapurna.
Yes, we call up for the day. Thank you.
Okay, bye. Bye,
ma'am.
bye.